going to talk a little bit, and focus in a little bit. And Adam has mentioned this a few different times with UGN-101, and he's been, crucial of using this as an alternative with endoscopic ablations as well as, as its own chemoablation. And there's some exciting new data, I think, that's coming out at this AUA, and hopefully will be on publication soon. So just ask him to kind of tell us about that.
Yeah, we'll just comment about the efficacy of UGN-101 and what we know, and based on the Olympus trial, and knowing that in terms of who had a complete response after induction, it was 58%, and then of those that had a complete response, about 56% were disease-free at a year. So we've then put together, as you've been part of, a consortium of people who are sort of real-world experience of using it, and the long-term data now we have seen, it was just under half that had a complete response after induction. And of those that had a complete response, we have a 68% recurrence-free survival at 3 years, which is I think really nice to see. One of the things that we've seen is that we've looked at what predicts recurrence. And there's no clear evidence that tumor multifocality, size, administration route did not align or correlate, I should say, with recurrence. It's interesting that it looks like the data are kind of soft, that maintenance actually likely helps in terms of reducing that risk of recurrence. And then another important thing to talk about, which is in higher volume disease, it is still a win to get downsizing and partial ablation such that you then can go back at your second ureteroscopy and get a full ablation. So that is still a win for the patient, and we see that of patients who had residual disease, and this isn't being presented here at the meeting, it was a prior publication, but that of the people who had residual disease, there was about 60% that then were disease-free after that re-look ureteroscopy. In other words, they were downsized and could be completely laser ablated. Yeah. And so that's that. We don't have the long-term data on that group yet, but I think it's a good win for our patients, and again, it's not everybody, but it's I think very helpful.
And appropriately selected patients. So I'd be curious, to say, then I turn to you, Alice, and say, you're early in your career. It's obviously exciting when new things come out and new data comes out, right? That involves what we do on surgically for patients. Hearing any of this data and being somebody new in your career, does it make you think differently about what you might do in the years to come?
Oh, absolutely. I think, this is a really important work, and that it really does kind of, you need to keep, early career, you need to keep updated on all of this type of data that's coming out. And, oncology, urology, it's constantly changing. There's new things coming out all the time. And, you have to be updated and be open to changing your practice, and it's just going to be constantly evolving. I did have one question actually based on the consortium you were talking about. I'm just curious, what is the route of administration that you see?
Great question. Great. Well, Dr. Murray, who's a real leader in that.
So I think Adam and I actually administered different ways, which is interesting. I've administered both in the antegrade and retrograde approach, with a primarily doing it in the antegrade approach, which actually has been a huge part of us now collaborating with medical oncology for nursing at our cancer center to instill gel-mito, because they obviously can't do cystoscopies and ureteral access. And so that's been very helpful for our institution. And if I recall, I believe in the real world data, we're about 50-50, as a general rule. And so that's kind of where I've done it. And I think that there's good protocols and good reasons in people's practice of why they do what they do.
Yeah, and I'll just comment. I mean, obviously, if you don't have a fluoroscopic unit in your office, then antegrade is much easier. Either way, antegrade is easier. I do both. And I have a discussion with patients. I talk about, all the risks and benefits, and give them a, and make a shared decision, basically. So I do both retrograde in the office and antegrade also. For retrograde, obviously you need fluoroscopy. You're replacing, the ureteral catheter. Not everybody has a stent. I'll make one comment that you have to pay particular attention to. Everybody worries about the risk of ureteral stenosis, right? So you have to pay particular attention to being gentle, how the catheter goes up, and and if there's any evidence that there's any narrowing, then you take a break and you wait. And the same with antegrade. If there's any concern of ureteral stenosis, you take a break. You give them a holiday. And it's debatable whether you use oral steroids or not. There's not really literature on that or data, but that I know some people are doing that, and maybe that helps. But yeah, I think there are those two options.
And you've treated a couple of patients, I think, with mitomycin gel?
Yeah, at our center, we do antigrade in our infusion center.
Yeah.
And do you give gel mito to patients with ureteral tumor, low-grade ureteral tumor?
Yes. So we have a paper on ureteral tumors, and so not just papers, but I mean, I see responses, and we do see responses in the ureter for sure. It's interesting, even in patients who have stents through treatment, we see responses because I think just as much gets down around the stent as through the stent. So we absolutely see treatment.
And what about the risk of stricture for ureteral tumor? Do you notice any
clear, if I recall the data correctly, the presence of ureteral tumor did not increase the risk of stricture, correct?
That is correct.
Yeah. So it's interesting. I think you have to be careful in how you laser those patients. Obviously, you don't want to do circumferential lasering. And that's, I think, where the win of downsizing with treatment with UGN, and then going back and having less to laser, I think is important. I will make one comment on low grade disease, and so I have a patient that had fairly high volume low grade distal ureteral tumor, and there was nothing above it. Okay, so and it wasn't really endoscopically manageable. That is a patient that, in my opinion, absolutely should have a distal ureterectomy and reimplant. The reason is because why would you put the whole ureter at risk for stricture when you've just got a distal tumor? So that, I think, is important for people to think about.
Yeah, and I do distal ureterectomy for patients with the distal ureteral tumor, whether or not it's low grade or high grade as well, because I think that is a very sound management approach.
And then you just do your
with a lymph node dissection.
With the if it's high grade,
if it's high grade,
with the high grade, then I do the pelvic lymph node dissection. Yep, absolutely.
And then you do your cystoscopy, ureteroscopy in the office through the
There you go.
anastomosis.
Exactly.